This morning you'll meet a doctor whose passion is compassion for the living and the dying. Coming up next on All American People. Good morning. Welcome to All American People. This morning we're at Conway Medical Center. We're focused on hospice and palliative care. And we're visiting with the medical director for the Conway Medical Center Palliative Care Service and the nonprofit hospice and palliative care program, Mercy Care, Dr. Charles G. Sasser. Good morning, Dr. Sasser.
Nice to see you.
How exciting.
Greg.
Did I just say your name twice? If I didn't, I should have. It's exciting to get you in.
Thank you.
And of course, oftentimes when folks think of hospice or palliative care, they may not think about that as an exciting topic, but I think for folks who learn more about it, they do get excited to know there is really something that may be addressing their concerns or their grandmother's concerns or their loved one's concerns. This is a really big deal.
After doing this for about 30 years, I can tell you it's really gratifying to see it really come into the mainstream of discussion. So I'm really pleased to be here too.
Absolutely. Is that actually what ultimately got you into palliative or hospice care? Was it just something like that, finding something gratifying in life?
Well, I think that I'm a physician who has to take care of people who are getting older. And as they get older, my medicine doesn't seem to work so well. And I can't keep them from getting older, and I can't keep them from getting sick. And they develop chronic illnesses, which the model of care that I have been trained in doesn't fit very well. And I discovered this as I was making house calls on patients back in the 70s, that I could go in and prescribe something perhaps if they had an infection or give them a prescription for pain, but the whole economic milieu and their social support structure and their spiritual crises that resulted from their disability, I had nothing to offer. There was nothing in my bag that would work for that. And I said, I can't do this by myself. This idea of being a doctor, you know, and taking care of everybody's ailments doesn't work anymore. People are getting older, and more people. We have this exploding population of people who are using a great amount of the Medicare dollars for illnesses that just are not working well in our current acute care medical system. So it's a major dilemma, and I came to the understanding that I needed help, and then I gravitated towards a model of care that indeed has an interdisciplinary team as its centerpiece. So it's quite a different approach to health care than the one I was trained in.
Were there many other folks focused at that time in this area on either, and of course we want to talk about the differences, albeit potentially subtle, as you talked about earlier this morning, between hospice and palliative care, but were there other folks in the area at the time, or was this really very novel?
Well, hospice as a concept actually began in the Middle Ages, but it really began to gravitate into the contemporary healthcare system in England at the turn of the 1900s, and then really began to take off in other parts of the world with Dame Cecily Saunders in the mid-60s. But it really did not come to this country until the 70s, and the Medicare hospice benefit passed in 1982. And so hospice has been pretty well established since then. There are now 5,000 hospice organizations in the country.
Wow.
So and we take care of about 1.9 million people who die of illness each year, which is about a little bit less than 50% of all deaths. So we still have a long ways to go. There are a lot of people with terminal illnesses who are being aggressively treated, some of them perhaps overly aggressively treated at the end of life. And this is due to a lot of reasons. Often families wish to fight on in the sense that I want to go down fighting, and et cetera, et cetera. But in any case, so it's been around, and I've been doing this for 30 years, the hospice piece, and we've watched the programs grow in this county, and all of that has been very gratifying. It's been now well accepted among both the medical and lay communities as an essential part of the healthcare safety net.
Yes, that's tremendous, Dr. Sasser. Well, let's talk real briefly, just so viewers understand, and so it's clear to me the difference between hospice care and palliative care.
Well, as I say, hospice began historically a number of years ago.
Yes, right.
But what happened in the rest of the world was that hospice and palliative care terminology is pretty much interchangeable.
Right.
That's because the healthcare structure of the rest of the world has a socialized component to it. And so it's very easy to move back and forth from one agency to another. That doesn't happen so well in this country, as I'm sure you know. And so basically hospice became founded in this hospice Medicare benefit, which means it was actually the first government HMO. So hospice is a concept of care. It is also a reimbursement mechanism, and it's an HMO. It's a rare bird because the providers are also the fiscal intermediaries for the agency. The difference between hospice and palliative care, they're both the same in concepts. They're both interdisciplinary. They're both patient and family centered. The family is just as important as the patient is, because we know that it takes a village to take care of sick and dying people. And it's very comfort focused. Okay, so it's somewhat of an alternative to very aggressive curative kinds of care. Now, where they differ is that hospice has a payment mechanism, palliative care does not. Okay. In fact, there's not one Medicare dollar spent for palliative care as an organization. Doctors and nurse practitioners can get reimbursed as they do in traditional care, but there's nothing that pays the social worker and the chaplain, et cetera, for that interdisciplinary team. So that's the big difference there. The other difference is that in order to go into hospice, you have to agree to forego your traditional Medicare, and you have to have a prognosis of 6 months or less if the disease runs its usual course, because none of us are very good at prognostication. In spite of all of our scientific knowledge, it's still a guess.
Things happen.
It's still a guess. There is no such restriction where palliative care is concerned, and although this state is a little bit strange about that, in truth, palliative care begins whenever you first understand that you've got a potentially incurable or life-threatening illness, because that's when the crisis really hits: economic, social, supportive, spiritual, multidimensional kinds of issues. Most of these take place out of the realm of the model that I was trained in, the biomedical model. 99% of the experience of a chronic illness is outside of the doctor's office in the hospital. It's at home. It's someplace else. Okay? You only come to the doctor when you're sick, or you may get a preventive exam, but you come to the hospital when you've got an acute illness, and then you go home as soon as it's better. So this is not the case where your chronic illness is concerned. You go home, you're still sick. You're still incurable. How are you doing? How are you getting along? How do you get to your doctor's appointment? Who comes to take care of you if your significant other is also down?
Right.
Who's there?
Yeah.
We
a
have
huge question,
giant holes
Right.
in our safety net.
Mm.
Palliative care has been rapidly progressive, especially in this decade, to try to fill some of those holes. And if you look at the rising cost of healthcare, Medicare in particular, where 10% of the Medicare population spends 63% of the Medicare dollar.
What 10% is that?
That's the 10% who has 5 or more chronic illnesses. Okay? Medicare spends $50 billion a year on the last 2 months of life. So it is a major expenditure for Medicare. And, you know, the other 90% are spending much less. They're the ones who are fairly stable. Now, we've got a population, a demographic challenge here. It has been predicted that by the year 2025, and this is 2011, 2025, the country will have 25% will be older than age 65.
Is that right?
Right. Guess what the current population percentage is in Horry County?
Of over 65?
18.
Wow.
We're almost there.
Right. And this is in 2011.
This is in 2011. So we're almost there.
Well, I wonder what it was 10 years ago. Do you, I mean, are any idea as you think back?
I do.
Right.
I can tell you that in 2000, it was about 16.
Okay, so this
14.
is a county that has remained in the teen, or is...
We have increased our numbers in the last 10 years by about 20,000 over 65.
This is just in Horry County.
Just in Horry County.
Just in Horry County, and of course...
and this 20,000 people need care. Many of them are healthy. They come from wherever. They come, they return home.
Right.
They come south to escape the weather. And many of them are playing golf 3 times a week and doing just fine, thank you. There are a significant number, the ones that show up in our hospital, then are the ones that now we've got a problem. Most of the time, their support structure is in New England, and we're talking to them by telephone. So the palliative care program right now is predominantly in the hospital.
Is this in all hospitals or just here at Conway Medical Center?
No, it's and it's a hospital movement at this particular point.
Right.
They're all grant supported. There's no Medicare dollars that does that. Either the hospital believes in such a program and supports it, or you get a grant. Duke Endowment gave us a grant that started us back in 2003.
Here, the Conway Medical Center's palliative care service, right.
But in 2000, there were 600 palliative care programs in the country, and now there are 1,550.
Wow.
So it's growing rapidly, and about 75% of hospitals over 250 beds will have a palliative care program of some sort.